So now we'll move to the next important session, diagnosis. Imaging in diastolic heart failure. This is one of the mainstay of this diastolic heart failure seminar. So in this context, I would now call upon Dr. Rakesh Gupta. He is the Director and Chief Cardiologist of Echo and Color Doppler Center, JRP, Institute of Echocardiography from Delhi. And Dr. S.S. Misra, he is the Director and Senior Consultant Cardiologist from Cuttack. And Dr. Sanjay Gambi, Professor and Head, Department of Nuclear Medicine, Sanjay Gandhi Institute of Medical Sciences, Lucknow. And Dr. D. Karthikeyan, he is a Senior Consultant and Head of Imaging Sciences and SIMS Center in Chennai. Over to Chairperson to conduct the session, please.
Thank you, Dr. Mahapatra, for inviting me to talk on this session to chair it. First of all, I'd like to invite the first speaker, Colonel Dr. Parashar, to talk on constrictive pericarditis. That's imaging in it. Dr. Parashar, as everybody of us knows, he is the Bhisham Pitama of Indian Academy of Echocardiography, the founder of Indian Academy Echo, and is known as the father of echocardiography in India. He is presently attached to Metro Hospital at Lajpat Nagar, Delhi, and he is one of those pioneer person who has been dealing with this field of echocardiography for last almost 40 to 50 years. With these few words, let me hand over a mic to Dr. Parashar, sir.
Well, thank you, Mr. Chairperson, and ladies and gentlemen. Over the next few minutes, I shall discuss some basic aspects of constrictive pericarditis. And being a mixed crowd, I will try to keep about 35 to 40% clinical and rest echo or so. Now, constrictive pericarditis, as you know, is very significant because it is a reversible cause of a diastolic heart failure, hence extremely important to recognize it. It is curable either by pericardectomy or reversed with anti-inflammatory therapy. And 10 to 15% of cases are missed if there is no index of suspicion. So the index of suspicion should always be on history, whether it is present or not, but it should be looked for when there is an unexplained dyspnea, there is heart failure with a normal ejection fraction and systemic congestion, there is unexplained edema, ascites, raised JVP, patients of tuberculosis, post-cardiac surgery, radiation therapy, who show signs of a right heart failure, then cirrhosis, many other diseases, especially restrictive cardiomyopathy, and lastly, most skilled diagnostician can still be confused in the diagnosis of a constrictive pericarditis. Now, besides the various clinical factors, the main imaging techniques are echocardiography, CT, and MRI. CT and MRI are complementary to echocardiography in the special situations, but as you know, echocardiography is the first investigation to be done in these cases. Now, there is always a doubt about pericardial thickness. Now, it is very difficult to measure from a transthoracic echo. A more than 2 millimeters is less reliable. A transesophageal echo more than 3 millimeters is more sensitive, but a chest CT is more specific in these cases, and a thickness of more than 4 millimeters is fairly diagnosis of a pericardial thickness. Now, why is it a diagnostic enigma? Because its basic pathophysiology is that there is a thick, scarred, adherent, and non-compliant pericardial membranes encasing the heart, and because they are non-compliant, the ventricle loses its distensibility, and hence there is an increased filling pressure in all chambers. The clinical effects of increased filling pressure in all chamber, on the left side, it is manifest as a cough, dyspnea cough due to pulmonary congestion. On the right side, increased right atrial pressure leads to an increased systemic venous pressure, and raised JVP, edema of feet, ascites, and low output. And these are some of the very diagnostic problems in these cases. However, if you have to diagnose a constrictive pericarditis, you have to demonstrate two mechanisms, either by MO, 2D, Doppler, anything. One is exaggerated ventricular interdependence. What is exaggerated ventricular interdependence is a normal pericardium regulates the coupling of the left and the right sided stroke volume during changes in preload. That means if the volume is less in one chamber, it slightly increases in the other one. In constrictive pericarditis, there is a fixed cardiac volume due to a non-compliant pericardium, and this, because it is a fixed cardiac volume, this pericardial coupling is greatly exaggerated. As a result of which, the alterations in volume of one chamber must by necessity reflected in change in volume by another chamber. For example, suppose a chamber increases its volume by 30 ml, other reduces by 30 ml. So the problem remains is that when there is a reduced LV filling, this leads to an increased RV filling because of the interdependence. This is very well shown here. During inspiration, when the right ventricle increases in volume, the left ventricle decreases because the septum is pushed toward the left ventricle. The opposite happens in expiration. In expiration, the LV volume increases, and because of ventricular interdependence, it is shifted toward the right ventricle. It is not only theory, we can demonstrate it. For example, this is one of our cases you see. This is inspiration, this is expiration. Now this is right ventricle. As you go in the right ventricle, as soon as the inspiration starts, you see the RV size increases and the increased RV volume. As a result of which, the septum is pushed toward the LV, thereby reducing the LV volume, and that is one of the mechanisms of pulsar paradoxes. Now here you see, as soon as the expiration starts, you see as that expiration starts, the LV increases in size, pushing the septum towards the RV and thereby reducing it. So that you can see the correct inspiration and expiration effect and the movement of the septum. The second you must demonstrate is a dissociation of intrathoracic and intracardiac pressure. We won't go into detail because in a constrictive pericarditis, there is effective isolation of the heart and there is an increase in the filling pressure of all the chambers. Because pulmonary vein is not covered by the pericardium, its pressure decreases. But because all other pressures are increased, there is decreased flow from pulmonary vein to left ventricle, leads to a decreased LV filling, and this decreased LV filling automatically leads to the increased RV filling, and this will produce some respiratory variation, which we will demonstrate just now, because there is a dissociation between the two. So there are various echo variables which we need not go into detail because of time constraint, but two are very important. One is known as the diastolic shutter. Now you see this is because of in every cardiac cycle, the septum moves either toward the right side or the left side at a very rapid speed. So this sort of a stutter or a jerky motion is seen. This can also be seen in various other, you see the short cases, in another case, there is a marked diastolic shutter in these cases. Second, the IVC always shows there is an increased, the dilated and plethoric IVC, as you see here, and it is believed that once there is no IVC dilatation or so, then it is in absence of diuresis, it should question the diagnosis, so that whenever we see the IVC, a suspect constrictive pericarditis, see the IVC, we always see that it is there, it is dilated. So there are 5 principal echocardiographic variables associated with this. We have already shown you a ventricular septal effect, which is most sensitive in 93% of the cases. The second, because of dissociation between the intrathoracic intracardiac pressure, there are a variation in the velocity. You see, in inspiration, there is more filling of the right ventricle, so the tricuspid velocity increases. And when in expiration, when the LV velocity increases, so this decreases. So that there is a variable filling during inspiration and expiration, as you have showed. And you see in the beautiful demonstration, these are the respirometer again. This is inspiration. You see during inspiration, there is a significant decrease in mitral velocity because of decreased filling. And in the first beat after expiration, you see there is a significant increase in the same velocity. You can see everywhere this is inspiration, this is expiration. This is because of this filling volumes or so, and the variation is more than about 30%, when normally it should be about 10 to 14% or so. The similarly thing we can see in a tricuspid flow. In inspiration, because it increases filling, the velocity increases. In expiration, because there is a increased RV filling, less IVC filling, so less this RV filling. So this also showed a respiratory variation. Now, this is something mostly for the echo people. A tissue Doppler measures the annular velocities or so. Now, what happens in a constrictive pericarditis? There is more of a longitudinal motion. And as soon as it fills up, it is suddenly stopped because of a constrained pericardium. So what this annulus records is the velocity of the annulus, medial and lateral, and because they are exaggerated, because most of the filling occurs in the early diastole. So what happens? This is the medial annulus. You see the early diastolic velocity is about 13, and the lateral diastolic velocity is always high, which is about 17. So this is the early diastolic velocity. So remember, in a normal individual, it is increased more in these cases, and you see the lateral is more than this in this medial. So one important sign is if annulus reverses. That means there is a reversal of the annular velocities. Now here what happens, that the medial velocity increases and the lateral decreases. So this is known as annulus reversus. Here it is 18 and here it is 12. So this is again a highly specific sign of a constrictive pericarditis, shown very nicely in both the lateral and the medial annulus. And the same patient, once they go undergo surgery, you see the extent of the annulus is reverses, significantly decreases because of this reverse theming. Now, hepatic vein, of course, we won't go into detail or so. There are some important variants of constrictive pericarditis. One is a transient constrictive pericarditis in about 7 to 10, constrictive pericarditis with normal pericardial thickness and effusive constrictive. And you know this is a transient constrictive pericarditis. It occurs in any condition leading to chronic constrictive pericarditis except radiation pericarditis, and it goes into the same phases: acute pericarditis, constrictive physiology, then it reverses back, and there is usually no results. So the impact of this is that whenever you see a constrictive pericarditis and patient is fairly comfortable, try to give a medical treatment for 3 months and observe. It may resolve in about 2 to 3 months. Only if the condition worsens and the clinical deterioration occurs, then the surgery is required. Otherwise, that is a good constrictive transient. A constrictive pericarditis with normal pericardial thickness has been seen in about 18% of cases, and it is clinically the same as thickened pericardium, and especially pericardectomy is very effective. So the message is, do not deny surgery in patients with a normal pericardial thickness if they show signs of a constrictive pericarditis. So the role of CT MRI is always important whenever echo is non-diagnostic. If you want to see the pericardial thickness, CT and MRI is the best. If you see the calcification, CT is the best. If you see the inflammation and the evaluation of restrictive cardiomyopathy, the CMR is much better, so that they are all complementary to each other. So this is my last slide to show that once you want to diagnose a constrictive pericarditis, start with a history. Go for a cardiac procedures, radiation, connective tissue disorders and infection. Then you go for a physical examination, especially JVP, to see for a too small sign and a more prominent X and Y. The lab ECG and X-ray may be non-specific. Then when you go, then you come to the advanced cardiac imaging. Both echo and other methods, they show two things. One is the anatomy and one is the physiology. Physiology is by Doppler methods, what we have shown the methods, and anatomy is by echo and other methods also. And if need be, then it is invasive. Now, this slide does not, time because does not permit me a very simple slide. utilizing echo, CT, MRI, and one single slide tells us the difference between a restrictive cardiomyopathy and a constrictive pericarditis, giving all the important features.
1 minute
Thank
left.
you very much.
Yeah,
Sir, in your experience, in your wonderful 40 to 50-year experience, how often is it that you require an additional investigation apart from echo, sir? Just wanted your take.
Sometimes we usually, although the signs, very rarely we have undergone an invasive, that is very, very rarely. But sometimes we have taken the help of a CT to see for a pericardial calcification. And as I told you, I had no time to show that slide. One single slide always covers between the constrictive pericarditis and the restrictive cardiomyopathy, which is the main diagnostic problem also. So we have just taken the help of a constrictive CT for pericardial thickness, but most of the other signs of echo are usually very well seen, though no one single finding is diagnostic. It is a combination of findings which should be seen rather than one single finding. A respiratory variation in mitral velocities can be seen in other conditions also. So sometimes there are certain situations where we have even taken a superior vena cava to study this. So it is when you combine everything, I think it becomes very easy to diagnose by this. But we have definitely taken the help of CT, MRI, which I have told you is always a complementary thing also.
Supposing the thickness of the pericardium is thin, but you had other diastolic features, what is the tip you can give to us that you will not miss it?
Say a mere thickness is not an indication that there is we have to see constrictive physiology. A large number of patients may not show any thickness, but they still have a constrictive pericarditis. Many of them may not show a calcification, but there may be constrictive pericarditis. But if suppose there is a thickness and you find all the features what we have discussed, there are 5 echo variables, then we would definitely go into that also. And the 3 most important ones are exaggerated ventricular intervention or M mode, number 2, a Doppler, a tissue Doppler, and number 3, a hepatic vein expiratory diastolic flow. If the ratio of the expiratory diastolic flow to the forward diastolic velocity is more than 0.79, it is much more diagnostic as compared to other things. So we
Wonderful.
just take the help of other things.
Wonderful. You need algorithm also, so you emphasize very much about the history and clinical examination, which is
That
equally
is
important.
most important.
Most
Clinical.
Supposing somebody has taken a radiation, the thickness may not be more, but
Yeah.
all these things has to be kept in. A wonderful
Yeah.
presentation, sir.
So, like earlier presentation also talked about, we are concentrating on the diastolic dysfunction today. So, I just want to know from Dr. Parashar, how good is echo in the early diagnostic, early diagnostic dysfunction? What are the variations? Can we really, the variations are small enough that the sensitivity and specificity is good in early diastolic dysfunction by echo?
No, the early diastolic dysfunction is only like a grade 1 also. But definitely the echo, if done properly, again, you start with a 2D echo. Now, a 2D echo will tell us whether there is a diastolic dysfunction present or not. Suppose the LA is not enlarged. Suppose there is no ventricular hypertrophy. Suppose there is no hypertension. We can be very sure that there will be no diastolic dysfunction present. So a clinical prerequisites are very important to see that these are the prerequisites for the, as Ponde said,
1 minute remaining.
hypertension, diabetes, and all these factors. When they are present, then we go for a variables, all variables also. And Doppler, as you know, is the first method echo to diagnose this, because there is nothing like early is only grade 1. So there are various methods. So there are various algorithms are done. One of the algorithms now taken by the Mayo Clinic in 2020-21 is much more effective. So it is helpful, definitely, no doubt. But there are certain echo features which go on increasing as the diastolic dysfunction increases also. So sometimes in early stages, there is no definition of early stages. It is relaxation abnormality or myocardial stiffness. By the time myocardial stiffness starts, your diagnosis will be much easier by Doppler as long as, unless it is a simple relaxation abnormality, which may be found in any number of cases also. So yes, definitely it is helpful once there is a slightly grade more than grade 1 or so.
We'll miss you at the end of this lecture, this series of lectures for discussion. We pay our regards. Thank you, sir.
Thank you. It's a wonderful session which is going on since morning. Thank you very much.